Hello everybody. Over the next 20 minutes we will learn how to read prostate MRI using AI software. Here are my disclosures. 3 objectives. 1. To understand that deep learning AI software can address some of the limitations of the current MRI prostate cancer diagnostic pathway. To realize which tasks deep learning software can address, particularly accelerating the data acquisition, tumor detections, and lesion and gland outlining. But to also, more importantly, to realize that some of the harms from false positive detections and false negative misses of deep learning software, in fact, are very similar to that of human readers. So we are all very familiar with the MRI pathway and what are the current radiological challenges. We don't need to go through this. We've been through this on a number of occasions on other videos. And AI can assist in a number of these areas, and on the bottom left-hand side of this panel you can see areas where AI may be useful. One of these areas is in the faster acquisition of the data and the pre-processing of the data before the AI actually looks and analyzes the data itself. Now, AI acceleration means that you can go faster and you can acquire images with a less probability of having motion. So you'll see on the left-hand side a conventional T2 sequence, 3 minutes 57 seconds, and you can see it's marred by artifact from the rectal air. In the center panels you'll see one acquisition using Deep Resolve Boost, an AI accelerated method that enables you to acquire an image with less artifact, and when you add the two images together you end up with that image on the right hand side, and that is in total 1 minute 48 seconds. So this is summated and registered to give you the final image, which you see on the right hand side, which of course is a better quality. Now you can leverage that AI to 1, go faster, or 2, to boost the signal on diffusion weighted sequences. So you can see that we've gone faster on the left hand side, but this is the 1600 as it's calculated from the baseline images. But if you use DR Boost, you can spend about the same amount of time but get much more signal to noise using the DR Boost to accelerate the signal to noise ratio. So here's an example of this in an actual examination using the biparametric MRI sequences, and you can see on the sagittal sequence top left a 4 minute 20 second image which is blurred by the presence of artifact. The same sequence in the sagittal plane again in about 2 minutes, much better controlled for artifacts, and here is the small Pyrex 4 lesion here and here are equally well seen. You'll notice I haven't used the Deep Resolve Boost to accelerate the diffusion sequences on this occasion. But let's talk more now on the analysis of the images. And the analysis of the images requires 5 basic steps, and these are outlined here. The first step is the outlining of the gland and the zones within the gland. Number 2, it's the detection of the lesions within the prostate gland. And number 3 is the classification of each of the lesions, in other words, giving it a level of suspicion, or LOS. Number 4 is getting rid of false alarms. And so in this particular instance, you'll see that the software, although initially analyzing 2 abnormalities, in fact eliminates the lesion at the back, which is the normal central zone, and that's false alarm reduction. And finally, it's the mapping and the contouring of the data so it can then be transmitted to a biopsy system. So these are the 5 basic steps. So if we think about the clinical use cases when we would like to use deep learning software, the first thing to say at the patient level is that all AI systems should ensure that the main benefits of biopsy avoidance are maintained. In other words, AI software should deliver consistent, high, patient-level sensitivity and negative predictive value, and that's how you ensure biopsy avoidance. AI software should lower the detection of false positive patients and improve the consistency of the positive predictive value. We know that human readers are not great at their positive predictive value. On average, it's about 50%, but it varies wildly between centers and radiologists. So that's another use case at the patient level. We would also like the AI to be able to help with indeterminate cases. In other words, PIRADS 3 cases. Increase, in other words, the specificity of the category 3 cases. And this, of course, requires an expert system. AI should, at the lesion level, identify and classify lesions that are most likely to be high-grade cancers so that they can be biopsied using a targeted technique. For the radiologists, the AI software should increase productivity and decrease some of the time-intensive tasks of reporting, particularly the outlining functions by automated, logically arranged, and a stepwise workflow. I think all of us would expect that. The software output should be clinically aligned. In other words, it should be explainable, actionable, that effectively contributes to the care of patients, including multidisciplinary care regarding biopsy decision-making. And AI outputs must accurately delineate the gland, the lesions for biopsy management. These are basically the clinical use cases for the use of deep learning software in prostate cancer detection. Here's a typical interface of a software on the same patient that we saw before. You can see in this particular instance, the AI identifies a lesion here in the left peripheral zone, and it's given this lesion a suspicion score of 4.1 out of 5, but it also identifies a second lesion here in the central zone, which is in fact a false positive. So how do you go about using software like this? Well, the first thing to do is to review all the AI-defined target locations, its segmentations, the level of suspicion of each lesion, and of course the entire glandular segmentations. And basically there are 3 pieces of software that I am familiar with, and these are outlined over here. The Lucidus software is the one I've got mentioned first. I like this one because it's semi-automated. In other words, it analyzes the data before I even get there. You can see that in this particular instance, it's imported this piece of software, but it's not analyzed it. These pieces of software have been processed. The overall patient level scores are given here. The number of lesions per case are also given here. And when there are no lesions, you can see it says no AI lesion findings. I like this because it tells me what to look at first and where I am in terms of the reporting priorities. The Siemens one is pretty good, requires the radiologist to manually run the AI, after which the results are accepted, rejected, and of course there's a possibility of report generation and a biopsy export of the ROIs. And finally the Quantib software, where heat maps are created, but there's quite a lot of manual work that needs to be done by the radiologist, who then segments and classifies the lesions according to their own training. There is some possibility of report generation afterwards. So here is the Quantib software in a different patient. You can see a small lesion here anteriorly in this man who has got a BRCA1 gene mutation. This turned out to be a 3+4 prostate cancer on a Templar biopsy. You can see on the right hand side I've got the prostate volume. The seminal vesicles are also outlined. You can see it's given me in fact 4 lesions, only one of which is a true lesion, which is this lesion here, which is given a suspicion of 4.1. You can see that this is semi-automated, prioritized work list of what are the possible lesions that I need to look at. Same patient, different software. In this particular instance, you can see this lesion here anteriorly in the peripheral zone. May be difficult to see to an untrained eye. The AI clearly points this out, but the AI only points this out once this button here is pressed. And if I want to then send this onto a biopsy, you can see I have to press this button. Here you'll see the LOS, given here level of suspicion, and level of suspicion is from 1 to 100, and here it says a score of 4. So a score of 4 is a level of suspicion of more than 80%, and the lesion diameter is less than 15 millimeters. And this is the export module that will send this outline to the PAC system so it can be used for biopsy purposes. This is the interface for the Quantib software. You can see it gives you a heat map, but a lot of the work that needs to be done in terms of outlining the lesions is not done by the software, but it's done by the radiologist. So a manual segmentation and classification has to be done. Now, whatever software you decide to use, you need to take into consideration the pretest probability of a lesion being a cancer. In other words, you need to look at the family history, the ethnicity, the biopsy history, the PSA density, with or without the use of a multivariate risk calculator. And of course, you need to take into account the patient's preference about how tolerant he is to a false positive or false negative result. Let me just show you what I mean. We know that the prostate cancer pathway is risk-based. So initially, the patient's risk is assessed by clinical assessments, by DRE, ethnicity, family history, biopsy history, as I've just said. But if once a decision is made about undertaking an MRI, there is a second and separate risk assessment that then takes the MRI into account. And here you'll see that the patient's preferences needs to be taken into account. So if your patient is cancer averse, then you would take a lower threshold for a biopsy. If the patient is biopsy averse, then you take a higher threshold for a biopsy. Let me just illustrate this concept with a patient. So here's a 52-year-old man, no particular family history, PSA is slightly elevated, he is biopsy averse, and this is what the AI output looks like. You'll see only the left side here is highlighted. The right side has been eliminated by the false positive reduction engine, and you can see in this particular instance the lesion here on the left is only just suspicious at 63%. You'll see a Likert 3 is between a level of suspicion of between 60 and about 80%. And if you put his values into a risk calculator, and this is the risk calculator that I prefer, you'll see that the risk of a positive biopsy is about 50%. The risk of clinically significant cancers on a biopsy is about 9%. So it's elevated compared to the background, but it's not that huge. Now, no biopsy was done, and a follow-up examination was undertaken, and you can see what happens over the next 6 months. His PSA continues to rise. His PSA density is now gone well above our threshold. Our threshold tends to be between 0.12 and 0.15, and this is above both. He's of course now more worried, so he's now cancer averse as being biopsy averse previously, and if we put his values in again into the same risk calculator, you'll see the risk calculator says that there's a 25% chance, 1 in 4 chance of this man having a clinically significant cancer. So that's how you take the preferences into account when you decide to biopsy this patient. And of course, in this particular instance, you can see that you should be biopsying both peripheral zones, whereas prior you would have only biopsied the left peripheral zone. Now, again, when you use the software, look at the normal radiological blind spots, the so-called radiologist false negatives. I just wanted to show you an example. So here's a man with a small PSA DRE lesion here at the right base. You can see it there. And there it is on the ADC map. And you can see the radiologist says, small PSA DRE lesion, right posterior peripheral zone, base requiring a targeted biopsy. He also mentions that there's a 12 mm polypoidal lesion in the lower rectum, which requires a endoscopic review. So the radiologist is obviously very happy because he's seen this lesion and he's seen this lesion, but he misses this lesion. So at the left apex here, there in fact is a small lesion, and on the dynamic contrast enhancement you can see it there, but it's not hyper intense on the high B value image. So this is a PSA DRE 3+1 essentially, and this was not called prospectively. Now if we had had the AI available at the time, the AI also spots this lesion. But what else do you notice? You notice that the AI in fact also sees the left apical lesion. In fact, the fact that the radiologist didn't spot this lesion meant that this man was left with an R1 resection at the left apex, leaving tumor behind, therefore needing some sort of post-radiotherapy salvage. Let me show you a different example. 52-year-old man, family history, PSA is 3.61, and this was reported as diffuse PSA DRE changes in the peripheral zone may be inflammatory. Consider PSA follow-up versus non-targeted biopsy. Now, PSA DRE should really be a focal lesion, but that's the report, a diffuse PSA DRE, and the level of suspicion is here by the AI. It says it's 73, so it's still putting it as a LUTS 3. It's saying, I'm not really sure what this is, but if you're going to biopsy, look at the right-hand side. And in fact, when this was biopsied and the prostatectomy was done, the main focus is located in the right lateral peripheral zone, measuring 18 × 8 mm, in other words, precisely at this point with a GG2 cancer. And in fact, you can see he was also margin positive in this area. If I'd used a different AI, in this particular instance, you can see that both sides were thought to be clinically significant with a much higher Likert score, 4.4 out of 5. So this AI is definitely pointing to the peripheral zone, but you'll notice here that the seminal vesicle segmentation is way off where it should be. So not all software is perfect all the time. You should also look at the AI blind spots, and there are AI blind spots. And so these false negatives also can cause harm, and the usual harms of a false negative is a missed cancer and a delay in treatment. So here is an example. So here we are, 2 lesions in the right peripheral zone and in the right anterior transition zone, and here they are on the diffusion rated imaging, here they are on the ADC map, and the AI only spots this lesion but doesn't spot that lesion. Now, this turns out to be a 3+3 cancer, so GG1. That's in fact false positive, believe it or not, and it doesn't highlight this lesion at all, which in fact turned out to be atypical ductal hyperplasia. Let's look at this AI. Well, this AI in fact says there are lesions in the front and lesions at the back. So it sees both lesions, whereas this AI only sees the lesion at the front but completely misses the lesion at the back. And you'll also see here how the contour is straying from the margin of the prostate gland here. So even this piece of software is not perfect. This is the cancer. This is atypical ductal hyperplasia. And here are the targeted biopsies. So this area here, posteriorly on the right, was 3+3 cancer, and this lesion here, more anteriorly, was ASAP, or a focal area of atypical ductal hyperplasia. Let me show you another example. 66-year-old man, severe LUTS, on active surveillance, but has a small focal lesion here, adjacent to the prostatic capsule. This lesion was biopsied, and the targeted biopsies showed Gleason score 4+5. So in other words, a very high-grade focus. The AI completely misses that. Can you see that? It completely misses this edge lesion. And here's another AI looking at the same data, and again that lesion is missed by this AI also. So look at lesions that are adjacent to the capsule. The outlining of the gland is in fact quite important. Here's an example of multifocal lesions in the prostate gland in a 73-year-old man, and you can see the AI identifies 2 lesions. Both of them it classifies as having scores of 5, in other words, like a Pyrex 5. And you can see this is 1 lesion over here, this is 1 lesion over here. But what you notice is that there is a 3rd lesion here at the right prostatic apex. But the AI completely misses this because the outline is here. So it misses the lesion that's adjacent to and on the outside of what it thinks is the prostate capsule. So just to reiterate, this was a 3+4 cancer, this was a 4+5 cancer, and this was a 3+4 cancer. So this outline here, instead of being at the back here, is responsible for this miss by the AI. It only identifies 2 of the possible 3 lesions in the prostate gland. Here's another patient. So here's another patient with a lesion in the left peripheral zone, clearly identified by the AI as being abnormal, and the AI also identifies a 2nd lesion here, but it gives this right-hand side lesion a much lower score. Now this patient was treated with androgen deprivation treatment. And after androgen deprivation treatment, all of us can see this lesion here in the left peripheral zone, which of course is going to be less cellular. And there's the diffusion, and there's the ADC, and the AI completely walks past that. Now that clearly is still cancer, but it doesn't have all the characteristics. So another lesson to learn, that ADT in this particular instance can alter the sensitivity of the AI. So let's talk about some learning points regarding false negative results. So false negative harms include delayed diagnosis and the start of therapy, small lesions at the base and at the apex adjacent to the capsule may not be seen, so we need to pay special attention in those areas. False negative cases include bilateral diffuse disease, small lesions, lesions outside the prostate segmentations, poor signal-to-noise ratio. And of course, in these particular instances, sometimes the DCE can be helpful, particularly if there is low SNR on the diffusion sequences. We also have to watch out for false positives. So what are the false positive harms? The false positive harms are patients undergo a biopsy leading to overdiagnosis, overtreatment, and then active surveillance costs, procedures, etc. So you need to be careful of false positives. So here's that patient that we saw previously. We can see that there is a true lesion here anteriorly, which we previously identified as being a 3+4 cancer. But if you look very carefully, you'll see the left peripheral zone is identified, the left central zone is identified as a false positive lesion. So in this particular instance, for one true positive, you've got one false positive per case. If you were to look at the same case with a different piece of software, you'll see that in fact the AI is highlighting both central zones as being abnormal, when in fact they are completely normal. So this is an example of false positive from a central zone. Another false positive which we're all aware of is, of course, infection. So here's an AI identifying granulomatous prostatitis in the left peripheral zone, and as you follow this patient over time, you can see that the inflammation resolves. I'll have to put the date onto this, onto that graphic on the bottom right hand side, which I think 2019, but I'll have to make sure of that. Another false positive is in fact a stromal nodule. So here's a man with a 3+4 cancer here in the peripheral zone. This was confirmed by a targeted biopsy, but the AI identifies this lesion here, which in fact all of us would call a stromal nodule. So a stromal nodule is a well-recognized false positive. Another different AI, same patient, you'll see in this particular instance, this stromal nodule is not identified as a false positive. So in this particular software, the stromal nodule was identified as a true negative. Another reason for false positives is this signal packing that you can sometimes get because of a large amount of rectal air. So in this particular instance, you can see that there's a large drop of air behind the prostate gland and another drop of air here above the prostate gland. And in fact, these two pieces of air result in this abnormal signal, which the AI identifies as being a lesion. Now clearly this is a false positive. The false positive caused by signal packing due to rectal air. Be very careful of that. So the learning points regarding false positives is that false positives or false alarms can result in unnecessary biopsies, exposure to the risks of overdiagnosis, and the costs of active surveillance procedures should something be found. The most common cause for false positives is the central zone, which can sometimes be asymmetric, signal pileup from air from the rectum, or even metal artifacts can cause false positive results. And in fact, you can use rectal preparation or anti-peristaltic agents to ameliorate this issue. Other common causes of false positives include group 1 cancers, stromal nodules, atypical ductal hyperplasia, proteinaceous cysts, or even post-biopsy hemorrhage. So just watch out for false positives also. Finally, you have to think about exporting the contours for biopsy assistance and to generate, of course, your template report. Now here is an AI identifying and outlining the peripheral zone, the transition zone, and the focal lesion. But what do you notice about this particular patient? Well, if you were going to undertake a biopsy, your region of interest would in fact be much larger. It would be the whole of this area, whereas the AI is only identifying this small lesion within this larger area. So although it's quite good at organ segmentation, zonal segmentation, lesion segmentation, not so good at the region segmentation. Let me show you another example. The same patient on a different AI. Again, it makes the same determination. So in this particular instance, just the whole gland and the lesion, but not the transition zone and not the region. So as we think about a manual of how to use AI assistance for reading prostate MRI, we need to account for the clinical history. We talked about this, family history, infection, ADT, etc. The quality of the images is important, particularly the signal-to-noise ratio and the rectal gas and how that would impact the T2 and the diffusion imaging. We clearly need to be careful about the outlines because lesions on the outside of the outline may not in fact be seen, and this can happen at the apex, but more often I've seen this at the base. Look at the lesions that the AI is showing you, because these are most likely in fact to be true detections. Review the heat maps without a defined ROI, because these are going to be false detections, but you may want to take these false detections into account depending on the patient preferences. Remember the common causes of false detections: stromal nodules, infections, central zone, rapid artifacts. Review the blind spots, remember those, small lesions, base capsule, subcapsular regions. Make sure you use the DC if it's available, and look to assign the PIRADS or LICAD scores on the multiparametric examination if that's available to you. Always think about this in terms of the patient's priorities, depending on their history, their PIRAD scores, the risk factors, and of course their preferences. And finally, export all of these to your PAC system so they can be used for fusion biopsy or even radiotherapy planning. And don't forget, of course, to do your report and make sure you bill. Okay, so if you want to hear more about this, please come along to the seminar on the 23rd of October, where we will discuss AI, how to use it, and some things about how you assess the performance of AI. Thank you very much for listening. I hope you found some of these comments useful as you think about how to use AI for your own practice. Thank you very much.